again the same thing.
Good morning, everybody. It's now 12 o'clock South African time or 1 o'clock Eastern time, 11 o'clock Nigerian time. I'll just welcome everybody. My name is Anna Forendran, and I just want to week 3 of series 4.
إننا نبدأ الآن.
I just want to also ensure
ودوا
translation in Arabic and Portuguese.
أن الترجمة باللغة العربية والبرتغالية.
We'll just make sure that when we speak a bit slower to ensure.
تأكدوا أن تتحدثوا ببطء حتى يتمكن المترجمون من الترجمة.
So welcome again from ICANN on this
إذن مرحبا بكم مرة أخرى.
collaboration on the webinars. And
أقدم لكم استعراضا لهذا الويبينار وهذا الاجتماع.
Of your videos to ensure we have a good
وحتى نضمن بأن لدينا أو ننجز اجتماعا جيدا.
You can put your questions in the question and answer.
ويمكنكم طرح الأسئلة في الجزء الخاص ب Q&A أو الخاص بالأسئلة تحت الشاشة.
We have a lot of experts on the panel from Africa CDC, WHO.
عدد من الخبراء من
With the information on the status of Africa on the COVID. I want to introduce Izini Unwekwe, and I'm sorry for the pronunciation of her surname. This is here to say Izini. Thank you.
أقدم لكم
Hi everyone, good morning. My name is Izini with Africa CDC, stationed at the Southern African region. So we'll just go through the EPI updates on the COVID situation globally and in Africa. Anna, if you can stop sharing your screen, I can share mine. Thank you. So I believe you can see my screen fully.
ويمكنكم أن تروا
Izini.
الشاشة.
Great. So today being the 3rd February 2021, this is the epidemiological situation of the COVID-19 pandemic. So let's take a look at the global situation. Currently, we have over 100,000 million confirmed cases globally, and more than 2 million people died at 2.2%. And if you look at the map on the left side of the screen, you can see with the indicators there, the countries and the ones that are more than a million and all the different categories. And moving to the right side of the screen, we've managed to separate the regions into the WHO regions, and you can see that the Pacific region is having the highest cases, and when we come down to Africa, which is in red, we can also even from here see how the cases have gone up till around July, come down, and now we are seeing increasing cases in Africa. But from the sorry. Okay. So from the graph already, we can see that Africa has the least number of cases. And so we're going to take a closer look at the situation in Africa as at this morning. And this is the graphical representation, and we've divided Africa into regions. And from the key, you can see the southern region is the one with the most cases, followed by northern, and then you have western and eastern then
Yeah,
East
yeah.
Central, and we can also see very clearly the first wave and the second wave, which
يمكن
appears
نرى هناك
happening around
الموجة
early
الأولى.
January, and now it seems to be coming down. And in Africa, the cases are more than 3 million, and
3
about
مليون
90,000 people have died. The CFR in
وهناك
Africa is a bit higher than that globally, and it's 2.6%. And 86%
نعم
of these are cases, which is about 3 million, are
حالات.
recovered. So now we go a bit more in detail, looking at the cumulative COVID-19 cases by member states.
نزلنا في التفاصيل.
Only one country, which is South Africa, has more than 500,000 cases.
جنوب أفريقيا
Countries are between 100,000
والدول
and
أكثر من
500,000, and you can
120
see that they are the
وإلى
darker
10,000
color. And most of them, a good number of them, well, it's
وهناك
scattered
عدد
in the continents, not really in one region. But then most countries fall between 10,000 to 100,000 and less than 10,000. And that's 22 for 10,000 to
أكثر من 2
100,000 and 23 for 1 to
24
10,000.
إلى
We don't have report from one
ليس
country,
لدينا تقرير
Tanzania, and I'm sure we are all aware.
وإنني متأكدة من
why.
أن
So
Sorry, can I just ask you, I need to just ask the interpreters if they can just look at the sound. At the moment, it's very difficult to hear you because we can hear simultaneously the translation as well on the English side. They can maybe
can
just
you
ask.
please check please change the translation to Kenny.
okay, so just continue. Thank you very much, Anna, for that. So this is now bringing in figures into the different regions, and the region with the highest CFR still remains, now it's the southern, followed by the northern, and we have the eastern, central, with western the least. And you can see the figures of the total number of cases, total deaths, and total recoveries. And we focused on the epidemiological week, the fourth week, which was last week. You could see the number of, in these categories, the figures for each of the region. So still trying to bring the figures into the situation. So we can see, as at yesterday, the number of cases per day, that is just yesterday we had. And we can see that the southern region is still the one with the highest number of cases each day, followed by western, and then northern, eastern, and central. And as well as the deaths are highest in the southern region, and no deaths recorded in central region. So looking at new COVID cases, population per day, we can actually easily see from the key and the map, almost all of Africa is, that's 41 member states have less than 40 cases, 1 million per day. Then about 5 countries fall in more than 1,100 cases per 1 million per day. And the list is just 2 countries that are between 80 to 100 cases. So you can actually on your own see the different countries and where they fall into. We don't have information on 3 countries. Then looking at kids' fatality rate, 3 countries report more than 5%, and they are mostly in the north. And 18 countries are reporting between 2.2 and 5. And most countries are reporting between 1 to 2%, which is 23 countries, and 10 countries less than 1%. And of course, we still don't have information from one country, which is Tanzania. And then finally, looking at the total COVID tests done on the continent. So the graph shows new tests and new cases and also the positivity rate. And currently, Africa has a positivity rate of 11.4%, and we have 8.8 tests reported per case. And in total, we've conducted about 31 million tests from when the outbreak started in February till 31st January. And that's all from me. Thank you very much. Over to you, Amy.
Thank you very much, Izini. It was great to hear this. I just want to say that we are working on the problem with the sound of the translation. And while we're working on that, please, if you raise your hand, we can only answer you in the question and answer box. We will have that at the end, and I'm sure they will sort this problem out now. All of these will be also available. You'll get a link for the recording of this. It will be also live streaming on Facebook from Africa CDC as well. And we will also be able to have the presentations to everybody that register. So from this, I just want to take us over, if Izini, if you can maybe then just stop sharing your screen. Then I want to introduce Professor Shaheen Mehta, that's going to do the next presentation. And then Professor Mehta, I think is somebody that everybody knows. She's been in infection control for the last 40 odd years, and she will take us through the ventilation in the area and discuss the transmission. Thank you, Professor Shaheen. Just unmute yourself, Prof.
Yeah, sorry, apologies, and I'm going to stop my video as well. So good morning, everybody, and thank you very much for the opportunity to address this webinar. There are many situations that we have to deal with, and as we go along, we have learned a lot along the way about this virus, this very, very clever virus. It has definitely baffled most of us across the globe. So my talk today would be on ventilation in the era of COVID-19, because I think there are some new developments and we have to rethink some of the way we have been considering the spread and the transmission. So hopefully by the end of this...
You see me there?
Yes, okay. Are we okay now? Right, so let's start. I'd like to start, if I can, with the case study. And this is a very famous case study about Gonju, where there was a spread in a restaurant, and it actually points to something. Could I ask Mr. Ali Elias to please mute himself, because it makes it easier for me. Thank you, very grateful. This is a very nice paper published in El País, which is a Spanish journal. And I strongly recommend that those of you who can should get hold of this. The link is here at the bottom. And it talks about 3 outbreaks that took place. But the one I want to, because of lack of time and other reasons, I want to talk about this very famous one that was published by Li from China. So basically what they have is that they have a restaurant, which is quite crowded. There's the air conditioning. There was no natural ventilation in this place. And of course, there were tables laid everywhere. So a family arrives from Wuhan, and that night, that person showed symptoms. So this was the person that actually was the index case. There's his family sitting around him. And what was of interest was that there were more people, 10 people became infected, 9 more being diagnosed, but they were only on tables B and C, not on tables D and E. And nobody else in the restaurant became infected. So what is also interesting that these were more than a meter away from the center one, and some of them were as far as 4.5 meters. So so the whole concept that we're looking at of distance becomes very important. But what Professor Lee points out very critically is that it was the length of time. So the meals from B and C overlap that of patient 0 for quite a period of time, whereas those from D and E only overlapped for 18 minutes. So what this basically shows is that the air conditioning here, and many of us live in environments in Africa where they do have air conditioning, that this played a crucial role, because what happened was the airflow, which are the blue arrows coming through, came out to patient 0, and this person who was now excreting the virus managed to blow it around in a way that was infecting people around here. And this was continuously going on because of the length of exposure, and there were virally charged microparticles that were going through. So I think this became a very important aspect. And there was also the Diamond Princess, there was the one about the call center and so on, but this explained very beautifully what actually happened. The next point about this is that, of course, can this be avoided? And that's the question we have to ask ourselves, particularly in Africa. And the answer is we are very blessed with good weather, and we do have open window systems so that if people are feeling uncomfortable, they can. Obviously, whenever possible, we hold the events outdoors, and we've talked about this over and over and over again. Within restaurants, we reduced the size of the gatherings and we increased the distance. But what was quite interesting is that if you can avoid background music, so people don't have to shout at each other and expel more droplets as they speak. Okay, and the second part is that you have to avoid, if you possibly, the recycling of air. Where applicable, we use filters. And I think this makes a very interesting study looking at the risk factors. So if you go into an environment where there might be carriage, which is either asymptomatic or pre-symptomatic, as was noted in patient 0, could it have been outside exposure? And the answer to that is that no, because many of the people that were infected here had no outside exposure. The other thing was, of course, the nearness of the tables, even though the furthest person on a table was 4.5 meters. They were quite close, and therefore the distance between the tables become more important. Families A and B had 53 minutes, of family A being the one where the infection took place, had 53-minute overlap. With C, it was a 73-minute, but with D, it was only 18 minutes, okay? So what comes out of this, of course, is that the length of exposure is crucial, and of course, overcrowding in underventilated areas. And I raised the point here about gatherings, mass gatherings that we all know about, which are happening in churches and funerals and so on. And in South Africa, we've been trying very, very hard to reduce this. We're now down to 50 people in a very large space indoors or 100 people outdoors. But the question is, do we need to have restrictions on people sitting outdoors? And we can come back to that and discuss it. Okay, so now coming back to some of the basic definitions, which you all know, and I won't spend a lot of time. The definition is that their droplet is that they have large particles that actually fall to the ground, and there are smaller particles that fly around. And this has been, very clearly demonstrated for TB, measles, and varicella. So in this particular situation for COVID, what has changed? So we have to now start reassessing the routes of transmission for C90 for COVID-19. And of course, this also has got to be looking at the infectious particles remain suspended, which contribute to the airborne infection, and droplets, which will involve the larger ones, were considered to be less than 2 meters. But of course, now we know that this could actually be longer. And these essentially become airborne. And diluting ventilation systems have very little effect on reducing the risk of near-range droplet transmission. So I think this is of interest to all of us, and that we have to rethink the way we organize our strategies around COVID-19. This was an absolutely excellent lecture by Professor Hugo Lee from Hong Kong University, which I have pinched because I took pictures of it. And what he looks at is something very, very interesting. It's the cloud of droplet dispersal. So what he works, and he's a professor of bioengineering and dynamics. He says, when you speak or cough or whatever, this is what happens, is that it comes out straight, but there is entrainment, which increases the level of the cloud. So in fact, the person standing in front of you, if you add 0.2 meters, you get a 16-fold increase. If you add 0.4 meters, it's a 32-fold increase, going right up to 1.6 meters, where you have a 138-fold increase. And this addresses the issue around wearing of masks and whether the masks should be worn just on the mouth or should the nose be exposed. But what I would like you to note is that this increased movement due to the entrainment of a cloud containing the virus goes from a very small area, which I'm pointing here, to a very large area to the person that's about almost 1.6 meters, let's say 2 meters away. So we have to rethink about what's happening. And this is by establishing a flow. And over here, we have actually established the flow zone. So it's quite interesting to see that even though the majority of it will be coming through here, the wider spectrum of the antrum will obviously include the nose. So when you're talking, it's the mouth that is important. When you're standing in front of somebody who's talking, it is both the mouth and the nose that's important. And that's why the masking has got to be such that it covers you right from the nose up to the chin. And I thought this was wonderful. He also talked about the inhalation risk versus the distance. So if you're in short distance, which is less than 1.5 meters, if there is poor ventilation, then you will see an increased inhalation risk, as one sees with the SARS viruses and influenza. If there's sufficient ventilation, then you will see an increase towards, as you go along, because now we're looking at the airborne and the aerosols, you're looking at TB, chickenpox, and so on. But if you're outdoors, the risk at distance is very good indeed. In other words, the risk is very low and the inhalation risk becomes very reduced. And I thought this was very significant and very important. And finally, his hypothesis is that inhalation dominates, that within the long range as a continuum of the short range. So there's no such thing as 0.5 or less than 5 microns and more than 5 microns. It's a continuum. It's a range that comes through from one area to the other. And he explains this very carefully, which I think is very cleverly done, showing that if there's direct exposure, there's closed range, that the closed range dominates. Of course, following the large particles are the smaller particles. They again are available for you to inhale. As you move along, and let's say there's a jet blockage or something going on there, or there's poor indoor ventilation, this then starts causing a problem. And in this situation, you're looking at masks working really well. And then, of course, much further along the line, you would see that if you go good ventilation and if you're outdoors, then of course the transmission is very low. So in this situation, we're looking at the indoor transmission, which becomes a very, very important part of how we acquire disease. And I think it's a very important thing to remember. So we summarize this first section by that there are no absolutes in science and biological transmission of SARS, and there's a spectrum, and there's of transmission modes and a continuum of droplet, and not simply just large and small. And so the number of particles released will depend upon the explosive nature of the event, like the singing or shouting or trying to talk over music. And the distance is likely to depend upon the event, the temperature, the humidity, we know that. But the particle size for SARS for SARS-CoV-2 do not play as big a role as we thought previously. And therefore, the non-pharmaceutical interventions become doubly important to remember even after the vaccination program. So the WHO talks about this. And I would just want to bring in some international information that in the context of COVID, airborne transmission is possible, but there has to be something that is generating aerosols. Now, we all know this. This is to do with moving patients, disconnecting them from ventilators and so on. So in other words, the source, which is the mouth, is now being exacerbated or exaggerated by doing things to it so that you can have more release of virus. And they also now acknowledge that there's an increased risk of transmission in overcrowded and underventilated spaces, and appropriate response is not increased, is not to increase prescribed general ventilation rates, but to rather avoid these areas. Okay, so then we come back to the whole story about if I increase the ventilation by turning on the air conditioner to full or adding bits like fans or whatever, does this help? And the WHO Committee on Ventilation, which I had the privilege to sit on, looked at this as well. So this is the recommendations. This is the document. It's called a roadmap to improve and ensure good indoor ventilation. And I don't want you to read the whole story, but basically what they're saying is that you use proper, where you can. If you can't use outdoor ventilation or proper use of ventilation using fans, then you need to have ventilation inside that is filtered. And you can try and find ways of disinfecting the recycled air, which is something that is not very doable in a low to middle income country situation. They talk about the built environment and looking at the ventilation rates, the airflow and the distribution. And of course, this is the way that you would be trying to work out a ventilation system for your indoor spaces. But there are some other stories coming out. And the one from Canada says that their experience in some settings in Taiwan and Toronto showed that the cohort of SARS patients without the use of airborne infection isolation, and this comes off the American way of looking at it, effectively disrupted its transmission. In other words, you don't need negative pressure ventilation. You just need good ventilation, good masking systems and in place, and obviously good care when you're dealing with it. Whereas the American Society of Hospital Respiratory and so on engineers, they talk about transmission is sufficiently likely that airborne exposure to the virus should be controlled. And they're saying changing building operations, including heating, ventilation, and so on to reduce exposure. So there are 3 or 4 different ways of looking at it. And my reason for telling you this is because I personally think that the WHO way is very sensible. And that is the way that we in Africa should be thinking about. In other words, improve the ventilation, reduce the number of people, and socially distance. I'd like to just come to South Africa, where we've done a huge amount of work looking at this, and this is the recommendation from the heating, heating, ventilation, and air conditioning group. And we have guidelines which already exist on the website of the IUSS. But basically, we again are saying in South Africa, you look at adequate ventilation, open windows to the outside when occupational health, safety, and security are not compromised, increase the airflow if possible, avoid recycling of air, so we know that's true, and that you should try and run filters if you're going to be running them for long periods of time. Okay. And it is, so we are not suggesting any firm guidance at the moment from South Africa, but it is prudent that this virus can only be considered airborne under special and rare circumstances, as based on the guidance from the WHO. And this would mean that we have to differentially filter it, and we have to look at general public places. And a very important point is that the engineers should not attempt to assume or argue that all indoor spaces bear the same risk. And I think this is something I'd like to leave behind as a message. You need to assess each area in its own right. This is the Hillside paper that's been published, again, talking very much about what's happening in South Africa and the advice that's given about decongesting. And we know this about open windows, increasing fresh air, and not recycling. But they have been very clever at putting together a matrix, which I don't think I have time to go into detail, but I would like to show it to you as a risk assessment matrix. So what they've done is look at the space, the risk of transmission, the initial risk, and what you do from an engineering point of view, and how do you reduce that risk. From the ICU to the surgical side, where the initial risk is severe or moderate, it reduces to low, depending upon whether the ventilation is sorted out or not. In COVID wards, again, transmission to the wards is low to start with, so it remains low, but transmission to the adjacent areas would be higher, and so you need to think about what you're going to do there. In general wards, the transmission within and from the wards are low, but in fact, there is the emergency center, which is high because there are new people coming through screening and fast tracking and isolation and so on. Hospital waiting areas, and this is a wide exposure type, and so therefore it's high, can be reduced to moderate by improving ventilation. And other public areas, which is waiting spaces outside, go from moderate, and there's not much you can do about this really. But if you're outside and outdoors and you are well spaced, then your risk is very low, and that in itself makes a big difference. So if we summarize this particular section, it is that first thing is that in the real world, SARS-CoV-2 in the air ducting or fans have not been found to be viable. And I think this is a very important point. Air sampling studies have failed to detect viable SARS-CoV in the ventilation system. Okay, so before you start panicking, it's really quite important that we understand this. So it's assumed that the ventilation systems have been designed well, and there's no reason for us in South Africa to change the configuration or pressurization unless general areas are repurposed for some other purpose. And so I just wanted to point out that I think what we're doing to date in most of the countries in Africa are doing the right thing, and we mustn't stress too much about it. Okay, and so the second point of it is coming to the fact that there's a spectrum of transmission that we now know not simply large or small. And the short range aerosol is important mode of transmission, and we've got a lot of epi data to support this. Opportunistic airborne, which is now looked at, the non-airborne turns into long-range airborne. In other words, if the ventilation isn't good, these remain suspended. And of course, we add to super events. Additionally, we don't know yet what the aerosol viral load is. I've been asking this question for a year. Nobody's been able to tell me, and nobody's been able to tell me what the infectious dose is of SARS-CoV-2. And I think these are important points. So I just want to talk very quickly about universal masking, and this is because there's a concept that has come up now recently about double masking and triple masking, and the more layers you put on your face, the better off you are. Can we start in the beginning where we look at Leffler's paper on 200 countries? This was published in June, work done in May, showing that if there was masking, they would have very low cases, whereas if there was non-masking countries, they were very high, and this can be demonstrated here. As you know, we can go through this. However, there's a very nice paper which was published showing that if universal masking carries on regardless of vaccination, 100 cases at the start of the month become 31,280 by the end of the month. But if they're masking, it's down to 584. And I think this is a very, very important point to take home. Okay. Before I conclude, I just want to say that there are some areas, like if you're going for your pension, where social distancing is not possible. However, in South Africa, we have the universal masking program, as you know, and this is there for the law. There are now questions rising about double masking. And the point is that if you have a really well-structured mask, which has got polypropylene spun bond inside and 2 layers of cotton on either side, it gives you up to 70% protection. So I think it's very, very important that we understand that. And wearing several layers of masks are not going to help. Wearing a mask under a respirator particularly doesn't help, because you can't get the fit to your face that you need with an N95, with the respirator. So I conclude and leave you with this, that improved ventilation will reduce, it will be much better. And you reduce the number of occupants and increase the airflow if you can by opening windows. But ultimately, and this is absolutely vital to all of us, and since this is a behavioral change session, I must say that the responsibility lies with each and every one of us to contain this virus by wearing a mask, distancing, and managing your hands with good hand hygiene. I thank you very much for your attention. I'm going to stop sharing.
Thank you.
I don't know if okay.
Yeah, I think we'll leave the questions until the end. Then we've got enough time for everybody to put down. There is some questions in the questions and answer box. But I think if we can move forward with Dr. Muhammad Lamorde from Uganda, and he's the head of Department Global Health Security Infectious Disease Institute at the Makerere University in Uganda. And he's going to give us some perspective of what Uganda is doing by repurposing public buildings for COVID. So I want to say thank you, Dr. Mohammed, and please over to you. If you can just make your screen full screen, please. Thank you. And unmute yourself.
So thank you very much for the opportunity to make this presentation. I was going to use this just to give a quick overview of some of the infection prevention control work that has already happened in Uganda, and then highlight just a little example of what we've done in public buildings as well. Uganda has had outbreaks in the past. Hand hygiene has been one of the measures we had always tried to emphasize. And even with that, we're facing challenges, and this is all before the era of COVID-19. The WHO core components are clear, and for COVID-19, what we did was to try and identify areas where we felt required strengthening on a system level across the country. And as you can see, these are the kind of topics that came out from the MOH guidance, from everything from learning more about what COVID is, to hand hygiene, respiratory hygiene, waste management, etc. And mainly because there were profound concerns around IPC in general, and this is in the health facility context. And so what was done, it was decided that a mentorship approach would be needed to enhance capacity for infection control in the country. Now, from Ebola's experience, we had done some work in a single district called Kasese district, where cases of Ebola were detected originating from the Democratic Republic of Congo, but then visiting into Uganda. And a low-cost approach in trying to get all the facilities within those districts sensitized to Ebola and to improve infection control was rolled out. In the current context, we realized that with COVID-19, you had to be thinking across the entire country. And one way to get to all country was to work with implementing partners that support government facilities nationwide. And a partnership was established with the HIV implementing partners. Essentially, the approach was to have the national level where there's a Ministry of Health pillar dedicated to infection control, and then work with our regional level. So we'd have a regional referral hospital, which is government, as well as an HIV implementing partner that supports that region. Ensure we can bring that information I mentioned to districts. Districts did not have IPC committees before then. There are about 140 districts. So we wanted each district to have 5 IPC committee members that would then be trained and then help to oversee what happens at facility level. Now at facility level, we would get one mentor, and the mentor would work in one of the government facilities and assign that mentor to 3 to 4 other facilities, and then use that to reach out to health facility staff on an ongoing basis. And this was the plan that we had, that in the first month, we'd actually have weekly visits where the mentor goes in. But on the first visit, the second visit, and the fourth visit, there would be a check in terms of the facility's capacity for infection prevention and control. As time goes on, the number of visits reduced, 2 in month 2, 1 in month 3, and the intention was to have monthly follow-up in terms of health facilities. Now, if you focus on the first thing that we wanted to focus on was really the screening area, and really using the outdoor spaces in health facilities as close as possible to the main entrance. And then, of course, ensuring that everybody is screened, not just patients, but visitors, healthcare workers as well. We followed the guidance that we got from one of our partners, funding partners, Resolve to Save Lives, and use this as a kind of chart where you'd have a screening area, but also have an outdoor area where people could be isolated pending admission. And the other experience we did was we realized that describing was often insufficient. And so we developed videos which were then posted on the Ministry of Health website so that people could understand all the steps that would need to happen. And because we used an objective evaluation tool, we were able to assess IPC performance across different districts by aggregating the scores from the health facilities. And in the first month, we could see objective improvements across all the areas that were supported. Here, I just put the districts that were supported by the organization I represent. But then thinking about that, you could strengthen IPC in health facilities, but then find out that in offices and other buildings, that people are not compliant. And as community transmission occurs, one realizes that you're just as likely to have infections arising from either the workplace or the home. So we wanted to also see how to improve infection control in our building. So this is our building within Makerere University. And here what we did is that we identified all the staff that are in the building. We have several different departments. And then we sort of set out a plan to ensure that we could reduce the risk of transmission in this rather large building. One of the first measures was to reduce the number of people that would need to access the building down to about 30%. and then provide guidance to staff in terms of measures that need to be taken in terms of spacing, masking, etc. Along the way, we felt it was necessary to assess to see if people were complying. And so there was a compliance assessment that was done in August. Following the compliance assessment in August, it was decided that interventions were necessary. And so what was done was there was an executive director briefing to all staff, and all staff were retrained via Zoom, I must add, on social distancing measures and face masking. And then heads of department were tasked to oversee what happens in various sections, and then followed up with a compliance assessment after that. And so what was done was that we would have somebody observing to see if our screeners at the main entrance were collecting temperatures when the people are coming in, whether the people coming in performed hand hygiene, whether they registered so that we know who was in the building, if an infection were to occur, whether the person was wearing a face mask, and then giving an overall compliance. And the bars that are in orange are the bars that were shown after the retraining was done. We also looked at the use of face masks, and we broke it down by different levels. So each floor would have personnel that have different types of expertise. And really looked at that. And what you will see here is that sometimes somebody has the face mask, but it is either dropped below the nose, or the face mask is at the chin after staying for about 3 or 4 hours in the office. And so being able to assess was important. So just having the face mask when entering the building is insufficient. So really what we conclude is that workplace settings can use an active monitoring approach to look for monitoring with IPC measures. We also looked at, for example, the use of hand sanitizers, but I didn't present that here. But what this means is that you could have management playing a greater role in encouraging personnel that utilize a building to comply. And by showing them the gaps, showing them the data, you're likely able to cause a significant improvement in behavior. So I just want to acknowledge all those that have supported this work. Thank you.
Thank you very much, Dr. Mohamed Lamode. It was great to hear from Uganda as well. I'm going to hand over to Dr. Yewande Alimi, which will take us through the questions and answers. Thank you, Wande.
Anna, and thank you very much, Prof. Shaheen and Dr. Mohamed. We have quite a number of interesting questions, but just to let our colleagues on the call know that we have experts from Africa CDC, from US CDC, ICANN, and of course our presenters who will also be answering most of the questions you have directed at them. So I will start with you, Prof. Shaheen. There are quite a number of questions for you, but I'll start with this one first. It says, in the wake of the new data and evidence on COVID-19 transmission that you have presented. Or are there changes being observed in the space? Over to you, Prof.
Prof, you're still muted.
No, I'm fine. I just missed part of the question, I'm afraid, because something happened. So could you just quickly repeat the question and I'll answer it? So in wake of the, oh dear.
On COVID-19 transmission, are there risk factors? Has there been any change?
I'm sorry, Wanda, you're breaking up. It's very difficult to hear.
Can you hear me?
I can hear you, Prof. I think, yeah, I think on Wanda's side. So let me just see what they were asking. I just want to go.
Was it that in view of the new data, what changes there are in? I'm terribly sorry, but something happened and I just didn't hear it. One day I can't hear you at all.
You're still muted one day.
Okay. Can I try to answer the question which I think was asked?
Doing it.
I think this was the question that was asked, and I apologize if I got it completely wrong and the wrong end of it. But I think the question was that in the new, in view of the new data that we have, should everybody be wearing a respirator? Is that what the question might have been? I don't know. And the answer is no, because as I showed you on Dr. Lee's paper, that very clearly that if you covered your nose and mouth, that you are going to be protected. And we know that with a cloth mask, with a good cloth mask, you say you actually protect yourself by up to 70%. And that work was shown by Mei Lu, who is working at Stanford University, very clearly showing that a good cloth mask with the polypropylene spun bond and the outside with cloth will actually reduce it. Not only, but the source is about 70%, and inhalation is probably at about 50 to 60%. And particularly the masks that we sent some in to be tried between South Africa, and they trialed the ones from Israel as well, which were really well made, and they had 70% sort of filtration. I don't know if that helps at all. One day, I don't know if you want to come back on again.
Prof, I'll take over. One day it's got some difficulty with the sound.
Okay.
So yeah, there's another question that I'm just going to put through to you, because I were asking, what do you think about the effectiveness of clear plastic masks sold in South Africa and used by many?
Yeah, well, I mean, you know, it's fine if you can breathe through it. It's very difficult to breathe through plastic, as we all know. That's how people get suffocated, by sticking their heads in a plastic bag. So, but that means there's a lot of leakage around it. However, they could have plastic in the middle here, and then have cloth around, so that they can actually get some movement of air. Because one of the questions was that came through, if I may, Anna, was that with universal masking and double masking, what about the oxygen levels in the lung? And of course, this is a very important point. If you are double masking, you don't really, you do increase the layers, but in fact, the leakage is also quite considerable. The oxygen levels, if you're universally masking, has been known to be fine up to 2 hours. And we have suggested to many of the institutions like schools and so on, and universities, or anywhere where people are getting together and they have a break, could they please go out after a couple of hours and have a mask break, which means you take off your mask and you breathe properly and deeply and in a clear open area, preferably not with a lot of people around you. So the oxygen levels are affected, particularly in the elderly, which is a reason that we don't want people wearing masks when they're exercising. But there isn't a lot of evidence that people have collapsed because of that. Thank you.
Thank you, Prof. There's another one before we move over to some of the other panelists. They ask, what is the percentage risk of aerosol infection via the unprotected eyes in some properly wearing a mask?
It's a good question, and I don't know the answer to that. Okay, it's a mucous membrane. So the assumption is always that if you've got AC receptors anywhere, that these will be vulnerable to the virus becoming attached. So most of the AC receptors are obviously in the nose and the mouth, back of the throat and so on. In the eyes, I have personally not seen any data on it, but the fact is that if you've touched a very contaminated surface with the SARS-CoV-2 and immediately rubbed your eyes, the good chances that you will get transfer. But I really don't know. I can't give you a percentage transfer, as I can't give you a percentage transfer through the nose, the mouth, or anywhere else, for example. Okay. So, but I'm sure it's very, very low. It's very low. You have to have a serious blast of the virus to cause a problem like that. But you know, please don't quote me on that. Yeah.
Okay, thank you, Prof. There's another one, just they ask on the comment of use of N95 by COVID-19 positive patients and the public.
Yeah, I thought I'd seen something like that, and I was wondering about that. The N95 respirator or the respirator is very specifically to prevent the source from you inhaling, not you delivering. So sticking it on a COVID patient will probably kill him. If it's properly fitted, it'll probably kill the person because they can't breathe at the best of times and they're very short of oxygen, and they're down to saturations of 86 or lower. So that's not a good idea at all. The only person that should be using a respirator, and this has been proven over and over again in the literature, has got to be those that are about to conduct a procedure that might be generating aerosols. And the reason is because of what the diagram I showed you. When you're that close to a person that is exhaling the virus, then your cloud is much heavier, and therefore the filtration by the respirator is better. If the guy standing on the other side of the gate and is wearing a respirator, it doesn't, there's no point. Apart from which it actually, if you wear it properly, it is very detrimental to the respiratory tract, as we well know. So for those of us that have worked in TB or any similar disease in the past will know that it is not easy to walk around with a respirator on. And so I strongly recommend that we reconsider that and only reserve it for healthcare workers who are going to be involved in aerosol generating procedures, not with the surgical mask underneath, but directly onto the skin. So it seals, it fits properly and gives you the protection that you're expecting.
Thank you, Prof. I'm just going to hand this over to maybe the panel, maybe Elizabeth or somebody from Africa CDC can comment on this, or even you, Prof. They were asking the new strain, what is the incubation period? The same 21 days?
Hi, this is Elizabeth from CDC. Good to be with Prof and everyone else. I think the new variants, well, first of all, we talk about, you say one variant, but there's, as we know, multiple new variants out there, variants of concern. So they're all under intensive study. I think we don't have any evidence to date to suggest that the incubation period would be much different than sort of the old variant that we know of. But again, it's all under intensive study and these new variants are popping up all over. So I think it's going to be hard for us to track down exact incubation periods for each variant. But I would assume that they're going to be roughly the same as the original SARS.
If I may just add to what Elizabeth has said, the answer is yes. It is a SARS-CoV-2 virus and it's very similar to the other SARS, and the incubation period is more or less the same. The only difference is that it actually travels better. It's cleverer, that's all. So you have to, we're keeping all the same procedures in place, all the same isolation facilities and so on and so forth in place. Thank
you, Prof. Thank you, Elizabeth. And I'm open up this to the panel as well. It could be Prof or Elizabeth or even Silas, anybody from Africa CDC, Dr. Iwande. They want to ask the risk of transmission inside an aircraft when there's no physical distancing. I can see you're smiling, Prof. So I don't know who wants to answer this one.
Well, since we wrote the document on it and we did the technical working group on it, I can advise you if you like. We have checked all the ventilation systems that have been from Boeing, that have been from Airbus, that have been from the smaller planes, and all of them have got excellent ventilation, which comes down from the top downwards. Okay, so it blows away from everybody. It then comes right down to the floor and blows out of the sides. All right, so that is not where the transmission is taking place. The transmission is taking place on airborne, and of course everybody's masking and they're also decontaminating their hands and all that. The transmission is taking place from the front to the back. So if in the entrainment, which I talked about, there has been, if you like, an escape, then that is possible, and it usually jumps 2 queues. So it'll have 2 rows. So it'll go one to the right or to the left or whatever, depending on how the entrainment goes, and it might go to the back. And that has been shown in about on the aircraft. All the aircraft have got HEPA filters if they're going to be recycling, which they do about 80%, and 20% fresh air. All of that is HEPA filtered. So the risk in an aircraft from the ventilation is not so high. In fact, it's probably safer than a motor vehicle, for example, or a bus or something.
Thank you, Prof. Anybody else that wants to just add to what Prof has been saying? Okay. I know somebody said they can't hear us, so please just look at your microphone or your, if it's on. And if you raise your hands, please put your questions in the question and answer box. It's difficult to answer raised hands. I want to put this question to Izini. They're asking and say thank you for the updates. They want to know if it's fine if the vaccine status along with the epidemiology. I think it will be fine if the vaccine status along with the epidemiology of the virus. If you want to just go and comment on that, Izini. I know there was a webinar yesterday on the vaccine and updates, what is happening, or anybody from maybe America, well, from US CDC that want to answer on that. Thank you. It looks like Izini is not on yet, so let's just drop that. I want to put this to maybe Elizabeth and Prof and Africa CDC. They want to know if we have the tools for compliance assessments. I'm not sure what compliance assessment Mirali is asking. Elizabeth?
Yes. There are many, many tools for compliance, for IPC compliance assessment out there. Actually, Mohammed, who gave a wonderful presentation earlier, basically almost referred to one of the tools that they used when they were looking to measure compliance, for example, with hand hygiene, mask use, registration at the front desk, and all of that. So WHO has a facility compliance checklist. CDC has a facility compliance checklist. There's certainly the standard WHO compliance checklist for hand hygiene. There are also, in many places, people have been developing compliance checklists for mask use, because we often see people in hospitals and even more in the community who sort of wear a mask as if it's a beard protector, you know, sort of down underneath the chin, protecting the beard, but nothing else. So there's compliance checklists for that, in the same way that you could use them for compliance checklists for hand hygiene. There's many. Resolve to Save Lives has been working with ICANN and WHO Afro and others to also develop a compliance checklist for primary healthcare centers. So there are many out there. And we can certainly provide, if Africa CDC doesn't already have, you know, a list of compliance checklists out there. I'm talking about compliance checklists at this point, mostly for healthcare facilities. I'm not aware of ones for offices, but I think what's used for healthcare facilities can be fairly easily adapted to offices. And I think Mohammed would also be a great person to talk about this, because they've done a lot of piloting and work with compliance checklists in Uganda. Over.
Thank you, Elizabeth. To comment?
Yes, thanks, Elizabeth. I agree. I think there are a range. The most important thing is to adopt one and use it consistently, and preferably adopt at national level, so that you know, all facilities under the same jurisdiction use the same checklists. What we just did was just have, as Elizabeth mentioned, was just to adapt one of the health facility checklists in order to be able to make a quick score as to whether screening was happening at the gate or registration. So these are really just tools to say yes, no for many of the functions.
Thank you very much. Somebody was asking for the compliance checklist. If you look on the website, as Elizabeth just mentioned, Africa CDC, WHO, CDC all have these checklists available. If not, you can't find them, just contact Africa CDC or ICANN, and we can try and help you with that. Thank you. I just want to also then put it to maybe Elizabeth or Africa CDC and Prof. They ask, what is the evidence available to prove the newer variant are more transmissible?
Elizabeth, you want to go? I can do that. Okay. So the evidence that the new variant is more transmissible. If you look at the data from South Africa, it's very interesting. I'm sorry I don't have it on me at the moment, but I can get it for you. But it clearly shows that we've been tracking the virus from the beginning of the outbreak, and this has been genomically tested regularly by KZN, by Dr. De Oliveira, Professor De Oliveira, Tulu De Oliveira, and his team. And what they showed was that in the beginning, they were looking at 2-3 variants that were coming along quite nicely. And then somewhere in about August, September, a little new variant appeared. Okay, and that was this one, the 501Y2, and within about 5-6 weeks, 80% of all strains in South Africa were this new variant. So it is highly transmissible. This has also been shown with the UK variant strain. It's been shown in Brazil. It's been shown in the Nigerian strain as well, I'm sure. But I think the point I wanted to make was that, and so now it's being called the South African variant, which has appeared in the UK in people that have never ever had any contact with South Africa. So my question is, this is again a spontaneous mutation. So spontaneously, this virus is clever enough to know it's got to move around. So it goes into variant 2 mode, or it goes into another mode, which allows it to transmit within the environment that it is. So the transmission has gone up by, I mean, it was amazing to see the data, which was about last month, and we were absolutely shocked to see how quickly this virus spread. From being less than 2%, it went up to 80% of all positive cases in South Africa. So it's not to be, it's to be reckoned with, I have to tell you. Very, very clever virus, great respect.
Thank you, Prof. Elizabeth, do you want to mention anything else?
Yeah, I think it's the same thing that Prof has been saying, that the data, showing that there was sort of a steady increase of, again, what sort of the original virus from China, showed, and then suddenly several countries showed this marked uptick in the number of cases, and it was not consistent with an uptick that was just due to climate, changes of whether or not it's winter or summer or anything else like that. And so just the data on basically the R0 and how it was going a lot faster and causing a lot more cases than before gives us some very, very strong indirect evidence that it is much more transmissible than the previous one.
Thank you very much. The next question I'm going to ask, and I will leave it open, but I think Prof will also answer this one, and Elizabeth. In an office 8x3 with 2 open windows at one end facing a door with apertures, when closed, having at most 3 occupants, what sitting arrangements will be best to reduce the spread of aerosol or droplets?
Okay, basically we do the same design as we do for TB, in that it's not a problem. If the windows are across from the door, then the doctor and the patient sit with their side to the window and the door. So in other words, if there's a door behind me, as you can see, and there's a window here, I will sit like this, so that if there's any movement, it's going to be laterally. In other words, it's going to go out either the door or the window. But not so much across. If I sit with my back to the door, then obviously if there's a window, a breeze coming from there, it'll blow into the patient and vice versa. So you basically place yourselves at right angles to the ventilation, or the air entry. I don't know if that helps. Elizabeth, you might want to add something, or Mohammed?
Yeah, I saw that question and I thought I would really need to see a schematic. I'm not sure I can answer it in the hypothetical, except for the principles that Prof just said, which is putting yourself sort of perpendicular to the flow of the air.
Mohammed, do you want to add anything?
No additions. I think that's clear. Thanks.
Thank you. There was one more question they were asking. They noted a majority of COVID-19 patients, if not all, are hyperexial. Is the infrared thermometer still considered an essential screening tool? Are there more tools that can be added for screening, for example, pulse oximeter? I don't know who wants to answer that. It could be anybody, Elizabeth or Mohammed, one day, Silas, Prof.
Anna, can you repeat that? I missed a little bit of that question, please.
They noted that a majority of COVID patients are all or most of them aporexial. Is an infrared thermometer still considered an essential screening tool? Do we have other tools that we can add, for example, a pulse oximeter?
And are you talking about a screening tool for clinical care or a screening tool for sort of IPC, separating people out who might or might not be ill?
So can we ask Tindudenda to just maybe clarify that, please? Just unmute yourself and just clarify your question that you asked.
Sorry to interrupt, but I suspect this would be in the clinical setting. Most of the screening areas tend to be busy, particularly if this is, screening at the gate and people are coming in. Typically, what would happen is that you would do the temperature screen, ask a couple of questions, but if people, if the screener suspects that the individual coming in might have COVID, they still get a clinical evaluation in a separate place. So I think that adding things like pulse oximeters in that second assessment seems like a more logical place to put it rather than, checking everybody as they come in. Thanks.
To me, I think a pulse oximeter is useful for clinical case management to understand how sick people are, because one of the marked things about this particular disease is that people can have very low oxygen saturation, but yet still appear to be fine and feel fine until they crash. So that you don't have, you don't see the kind of normal gradual decline in function and oxygenation levels. So I think it's very useful in a clinical setting. I think in terms of screening, just to see whether or not a person might or might not have SARS-CoV, and whether or not, whether or not that is it going to then make you have a judgment about what waiting room to sit in, or what, or whether or not someone should even enter a facility. I don't think it's that useful for that purpose, personally. It's expensive. Not everyone knows how to use it. It's not that sensitive. And I don't know what you would actually do if you found a person who was afebrile but had a relatively low pulse ox, how you would actually treat them differently from an IPC point of view than you would anyone else, because I think really you have to make the assumption that almost everybody has the virus. We know there's a lot of asymptomatic transmission. And so even if somebody doesn't have a temperature and they're coming into a healthcare facility or coming into the office, I still make the assumption that they potentially have the virus and are potentially spreading it to others, regardless of what a pulse ox or a thermometer would tell me. Over.
Prof, do you want to add maybe to that? You're muted. Prof. Shaheen, you're muted. Do you want to add?
No, I'm fine. I love the explanation Elizabeth gave. Thank you very much.
Thank you. The next question I'm going to ask is, how effective is surgical masking in preventing COVID-19 infections? I think we've already touched on that, but it seems like people are still a bit unsure. Do you would just want to go through that again, Prof, between you and Elizabeth and maybe Mohammed? Thank you.
Sorry, again, I missed it. What was the question quickly, please?
They want to ask, how effective is surgical masking in preventing COVID-19 infections?
Well, how effective is anything in preventing COVID-19 infections? A surgical mask is to protect the wearer, okay? And it will give you protection if you look at the standards from the United States as well as from Europe, the CDC publication, and I'm just trying to think of the other one. This was in April when we did all this work. But basically, it gives you about a 60 to 70% protection. In fact, the paper I can now remember was comparing a well-made cloth mask with a surgical mask with the respirator. And the surgical mask was as good as the cloth mask, or the cloth mask was as good as the surgical mask, but the respirator was better than all of them put together. And that made it, so it was 65 to 70%, 70 to 80%, up to 95% for the respirator. I remember that paper now. So,
just wanted to add that,
yes,
you know, when it comes to the masks, we have to think, you know, with a public health approach. If you have masks that have maybe 60, 70% efficacy, and then people use them intermittently, then, you know, you're even getting less protection from the masks. So I think as leaders, what we want to see is everybody in the team using the mask consistently. And then what we're really talking about is a 60 to 70% reduction in the number of people that would get infected. So if we think about them that way, rather than think about it from an individual, single individual's perspective, then we see that we can really make a huge difference by promoting their use.
Yeah, I did show the data on the mask usage, but I only chose one of the talks. But it quite clearly, I mean, the countries that have used masks consistently, universally, have got much lower rates of mortality than other countries.
Thank you, Prof. The next question I'm going to give over to, maybe if Elizabeth can answer this, and then Prof can share hers as well, because we just discussed it this morning. Is ivermectin a drug for prophylaxis or for the treatment of COVID-19 infection good, or should it be used? So we all know this has been in the social media quite a lot. So Elizabeth?
I personally have not seen any data that would compel me to use it. Over to the others.
Thank you, Elizabeth. Good escape. Okay, ivermectin, as you know, is a drug that is being used by the veterinary side for a long time for deworming. Has been used in humans, sort of, if you work on a farm or similar, or for scabies, there is, it's used for parasitic disease. Now, its indication in COVID-19 infection is not very clear. The published data doesn't actually show any risk benefit at all. Okay, so what's happened in South Africa, because there's been so much pressure from the GPs and from other organizations, the Ministry Advisory Committee has said that we're really not very interested in this drug because there isn't enough published information. However, the South African council that is for allowing drugs and so on, like the equivalent of the FDA, called SAPRA, they have said that they will release ivermectin on a patient basis, on a named patient basis, for prophylaxis or for treatment, depending upon what you want to do. Okay, so we are very much between a rock and a hard place. And the second question that we need to ask is, do we need ivermectin? Is it better? To my mind, I don't think so. Is it better than using the NPIs? In other words, using the non-pharmaceutical interventions that we've done to date? Or are we using it as a stopgap because we don't want to do the non-pharmaceutical interventions like wearing your mask properly, distancing, and so on? If that is the case, if the latter is the case, does it protect you enough so that you can walk around without a mask? And the answer is no, it doesn't. So I think I'd be very wary of going down that path personally at the moment because of the lack of information. And I'm sure there are studies to be done shortly where you will actually find more people in that situation.
Just want to add that the World Health Organization is tracking this, and there's some sort of well-conducted clinical trials that would answer this. Just to temper the optimism, a lot of the chemical entities that are antivirals, that are proposed as antivirals, tend to disappoint at the later stages. So you see some promising information, a lot of people run in the bandwagon, and then you see that they haven't done as well. Interestingly, it's the monoclonal antibodies, surprisingly, that seem to have carved a role for themselves in infectious diseases moving forward. We've seen this in Ebola, where monoclonal antibodies were seen to be effective. So I think there will be more research, particularly around the monoclonal antibody area. And then if we're really lucky that we can repurpose ivermectin, we should wait for WHO guidance on that.
Thank you, Mohammed. The next question I'm going to give to Prof. Shaheen. She said she would like to answer this live. The scientific difference between social and physical distancing. Do we continue using these terms concurrently? Prof, over to you.
There's no difference. It's exactly the same. It depends on which part of the world you come from. Some people don't like to call it social distancing because it's got implications of you not liking the person next to you. Physical distancing means that you just want to make sure that they're not within arm's length of you, but that's the only difference. So you can just call it distancing, okay, without having to call it either social or otherwise. And I think that's about the extent of it. Thanks.
This is Elizabeth. Completely agree. I think it started out as social distancing, and there was some movement to call it physical distancing because we want to acknowledge that humans are social creatures and need social interaction. So we don't want to suggest that you don't socialize, but that you just do it from a physical distance. Hence some of the, some people wanting to change the term from social distancing to physical distancing.
Thank you, Elizabeth. Thank you, Prof. The next question I'm going to hand over to open up to the panel. They ask, what is the precautionary IPC measures to put in place to stop spreading of COVID-19 amongst medical lab scientists in government hospitals? There's a shortage of PPE material for use by healthcare workers.
I can have a little go first because we dealt with this right in the beginning of the epidemic. We had 7 lab techs in a particular laboratory that was brought to my attention. And when this was investigated, it became quite evident that this was not acquired in the lab, but was acquired in the tea room. And what happens in the tea room is they all go away and they throw off the PPE, thank God, and then they all relax and they share phones and share food and share drinks and have a general chat and the other. So that is where that infection took place. As your concern would be that, is there somewhere in the lab? So you're talking specifically in your case, a virology lab, because that's where you think the COVID will come from. Well, in fact, there's nowhere in the virology lab that you should have any exposure to SARS-CoV-2 because of the way things are structured and the way samples are taken and they are used in testing. So in the work environment of the lab, there isn't any problem. In the social environment of the lab, there is an issue. However, I notice also from your question, what happens if they're short of PPE? So I'm going to say something that's very contradictory to IPC, and please, 450 people don't kill me all at once. But in the laboratory, the use of PPE is to protect the lab tech. Okay, it's not to protect patients. So if you're short of PPE, the question to you is, are you so short that you can reuse your gloves? I mean, obviously you can, wear the same lab coat or the same apron or whatever, fine. But if you're so short, can you reuse your gloves? And then you have to work out a way of reusing the gloves as and when you need to use them. But I personally don't think that you need you should not be short of PPE in a lab. The only place that I insist that you actually have good PPE is, of course, is a level 4, which is a TB laboratory. You must have very good face covers, particularly respirators and covers, because of the aerosolization in sputum. I'm sure Elizabeth or Mohammed could add to that.
Completely agree.
Agreed.
Thank you. One other question was, they asked, how does all of this affect future service and infrastructure design? Prof, and I think you will want to answer this one. And maybe.
Yeah, well, it doesn't. All it does is for you to be vigilant in those spaces. Look for windows, open them. People are going to complain because the mosquitoes, the flies, and of course the heat. Think about it. Increase the distancing. make sure that people who come in are not all there all together to collect their pension, but in fact, if they could be spaced, that would be fantastic. The other day we saw one as I was going to a particular place, that there was a queue that used to be that used to be quite short, is now literally around the block and away, because there are people monitoring to make sure that they stay apart. And I don't think even though we're seeing a lot more new information, it's not directly affecting the IPC policies that we put into place in March. They seem to be exactly the same. If anything, they're reinforcing those policies, particularly with the non-pharmaceutical interventions. Sorry. I would love to hear from Mohammed and Elizabeth on this as well.
Yeah, hi, it's Elizabeth again. I'm wondering if it will make us think a little bit harder about where we put people for screening and triage as people are coming into hospital. You know, we used to always have sort of a cough corner, you know, and the assumption that maybe somebody has tuberculosis, but I think that was variably enforced. And I wonder, you know, with this and also with the experience of Ebola, and I think Mohammed, it'd be quite interesting to hear, again, the experience of Uganda that have had both Ebola and COVID. You know, we've put so much emphasis on, you know, having a tent, having some other ways to screen people, to sort of limit number of visitors to a hospital, to you know, try to catch people early in their symptoms, put them off somewhere else. They're not sitting in a waiting room. And I'm wondering, again, if future building of structures will take that into account to do better screening as people are coming into healthcare facilities, in order to separate them from, you know, separate symptomatic people from asymptomatic people.
Yeah, I mean, Elizabeth, I agree. I think the future hospital in Africa, and I think this is actually the kind of place where Africa CDC can be very helpful. Most governments would have their infrastructure designs for their health facilities that are set. You know, being able to review those and see such that when countries get additional resources, the next generation of hospitals that they construct sort of take into account the kinds of threats that we are seeing. Having said that, you know, many rural hospitals and, you know, the hospitals in smaller towns tend to already have this outdoor sitting area for antenatal and things like that. So I do not think it's going to be a major shift for many countries.
Thank you, Mohammed. Thank you, Prof. Thank you, Elizabeth. I want to just give this one as well. They ask, what is the current information on COVID-19 burials? Prof. Elizabeth, I don't think there's anything that changed, but just hand over to you.
Okay, so I can add, because we've just finished writing the third advisory on this matter. For some reason, people started being wrapped up, not people, but dead bodies were wrapped up in cling film, and then the coffin was wrapped up in cling film, and caused a huge disaster with the African community as well as others, because there is a very important aspect of being buried and how you are sent off in this particular way. Which caused much chaos, and it caused lots of bodies to be exhumed quietly at night, illegally, and then the wrapping taken off and the bodies reburied, which is a bit silly. That I don't know where that came from. It is not in our advisory, but what I can tell you is that there is absolutely nothing, that there's no evidence of any transmission from a dead body. There's a constant confusion between Ebola and SARS-CoV-2. And I don't know why it still is going on. I can imagine, okay, in February, that was true. But now looking at a year later in February, I mean, people must have understood that one is transmitted via blood and replicates in the body pre-death. And the other one is via the respiratory tract. And when the body dies, it dies. Okay, there's nothing going on over there. So I think it's really important. Sorry?
Yeah.
Sorry.
No, so we had the same problem in Uganda because, you know, Ebola is, you know, people switched to the default. We had few deaths and they came late since the start of the epidemic. But, you know, full PPE, burial teams, spraying with bleach, traumatized families. So right now we're working with the Ministry of Health to retrain funeral homes, districts, health facilities. And as Professor Mehta said, if dead bodies are coughing, sneezing, talking, then COVID-19.
Yeah, but I also want to just say that if the family needs to bring in their own blanket to cover their loved one, it can be used as a shroud. So what we've said is that we use a black bag from the hospital bed to the mortuary. After that, you can use the normal safe ritual that you have, okay?
Correct.
And I think it's really important to remember that, and otherwise it's too traumatic. Yes, Mohammed, sorry, I'll just mute.
No, completely agree that, you know, cloth covering can be used. I think we have to destigmatize burials from COVID-19. What we really need to focus on are the crowds that gather for funerals. In Uganda, we still have about up to 200 people allowed to attend funeral. I know South Africa has reduced that to at least 50, I think, to at most 50. I think as IPC, we need to communicate that, you know, you're more likely to have transmission when people gather for the funeral than have transmission by somebody attending to the burial,
Yes.
to the end of the day.
I think you're more at risk from the people who are alive at a burial than you are from the dead person.
Thank you,
That's
everybody.
exactly what we said.
Yeah, I think the last question that came to ask if it's compulsory to put the corpse in a body bag was just answered. So I'm going to ignore that one. The next one I want to do, we've got two more. How can households with young school attending children limit the risk of transmission in the home in case the children get infected at school? Prof?
Okay, so our school going group had just finished its advisory for the Minister of Health of South Africa and the Minister of Education. And clearly, if the child is infected, then the whole family is exposed, and therefore they will all quarantine or isolate. Okay. Children at school, the transmission seems to be quite low, particularly under the age of 12. And the transmission amongst teachers seemed to have been from the community, but there has been some incidences which could not be explained by community transmission. So the belief is that it was transmitted from the children. Now, there's been a paper from the United States, if I can remember, actually looking at this very clearly, and I will look up the reference and I will let you know. There are papers from all over the world now looking at the transmission in healthcare, in schools. But from the parents, if your child comes back and is found to be positive, we need to make sure that the whole family understands that they are at risk and that they need to be isolated. The 10-day thing.
I think one other thing to add is that, you know, if families have the means, we know that in many African families, you know, you have grandparents, parents, you know, grandkids all living together. If families have the means to separate out vulnerable members of their family once children start going to school, because, you know, it's really, really difficult to prevent transmission once somebody in the home has it. So separating vulnerable household members, I think, is key, and this includes diabetes, elderly, you know, just to make sure that if it were to happen when children start school, you sort of have some way of preventing that from spreading to the vulnerable person.
Absolutely, and tagging along with what Mohammed just said, separating out the vulnerable members, and then also having a lowered suspicion for any kind of symptoms for the disease in people who are in the household, and getting them to medical care if you know that there's some, you know, especially in a vulnerable person, if you know that there's someone else in the household who currently has had the infection.
Thank you very much. There was one more question that they wanted to ask, and I would leave this to all three of you to maybe answer. Would compliance assessment for IPC control be best regarded as part of evaluation, monitoring, or as an audit? Elizabeth, Mohammed, and then Prof.
I think in some ways it should be routine monitoring. The best way to do it is to keep it up as routine monitoring to make sure that best practices are followed. I often think of audit as being just, once in a blue moon that you look at something and evaluate it. But I would say that compliance for IPC should be built into healthcare facility monitoring system that they have to ensure safe provision of medical care.
Thank you, Elizabeth. Mohammed, do you want to add anything, or do you
No additions, thank you.
Prof?
I'm fine, thanks.
Okay, then the last question is actually, I don't think for this forum, but maybe if one of you wants to answer this. They say there's quite a number of people, healthcare workers and public, who have expressed their hesitancy to take the COVID-19 vaccine. How can this be handled? Because mainly this is due to fear caused by lack of knowledge in the vaccine. Over.
This is a huge question, if I may answer it. It's a huge, huge question. There are anti-vaxxers all over the world. There are people around who say that everything that's ever happened has happened because of the vaccine. For those, there have been 10 million people that have been immunized, vaccinated to date. And I think it's really important to understand what is expected of this vaccine. It is not a magic bullet. All the vaccines, there are about 5 of them going, another 7 of them in the pipeline. It's not a magic bullet. What it actually basically does is if you are infected with the virus, it doesn't stop it attaching, okay? If you are not infected with the virus, it doesn't stop it attaching. What it does is it stops you getting so sick that you land up in hospital and that you and your oxygen saturations drop below 84, and that you basically die. So what it does is it actually prevents you from dying. To put it very, very simply, in a nutshell. Okay, now the question of why people don't want to use it, there hasn't been enough research in it. That's not true. There's been a huge amount of research. I mean, people have fast-tracked the research for all 5 of the vaccines so fast that it's unbelievable. Number 2, they're saying that we're getting side effects. So there are 2 situations where you could actually, the virus, the mRNA vaccine component can very well give you a slight headache, a fever, joint pains, very similar to a mild case of flu or whatever, as one does with the other jabs. But the second part of it, which is quite important, is that there are people who might have actually had quite a nasty reaction. Okay. And there are about 5 or 10 of them. I think in the United States, they've got about 15 of them. Then now, but if you are symptomatic, you go for the vaccine today and tomorrow you develop full-blown, not full-blown, but all the symptoms of COVID. It doesn't mean that that came from the vaccine, okay? It could have been pre. So I think it's quite important to put it into perspective. There isn't enough information on the long-term effect of this thing. But as it stands at the moment, it is an adjunct. It's not a panacea. It is an adjunct to supporting the reduction of infections by reducing the number of cases that die and the number of cases that go to hospital and then die. All right. And I think we need to put this into perspective. So I've just had some messages here that people said that with the Pfizer vaccine, they developed Bell's palsy. It's possible, Doesn't mean that every guy that gets the Pfizer vaccine is going to get Bell's palsy, because the whole of the United States would have got Bell's palsy by now, all right? It doesn't mean that they're going to get, so I think the point is that as this goes along, more and more will be known about it, but there is no vaccine that is perfect, and doesn't matter what you say. The anti-vaxxers will build on it and will develop on it, but from an African point of view, since we don't test and we don't know what's going on, one of the things that will reduce the mortality and morbidity will be vaccines, if you can get your hands on it. And I'm sure both Mohammed and Elizabeth would like to say something about it.
Is there any more comments from Mohammed or Elizabeth?
No, I just think that vaccines are such a big issue. I think we will have lots of conversations about vaccines. Thank you.
Yeah, it's a challenge here in the U.S. as well to get people vaccinated. All I have to say is it is true that we don't necessarily know the long-term consequences of being vaccinated, but we also don't know the long-term consequences of having COVID. And right now, I think I would much rather be vaccinated than take my chance on either short or long-term consequences of COVID. I feel like the vaccine will give me much better protection. But it is something that we are all going to have to work on very, very hard in instilling trust into the medical system, and in trying to address conspiracy theories, which are so easily spread, and show that the medical system can be trusted. And part of that is also doing IPC in the medical system so that people have a decreased chance of getting any disease when they go into a healthcare facility.
Just to link to what Elizabeth said about addressing conspiracies, and I think that health workers are really, really important. If we can get health workers to have the correct messages, they are opinion leaders. What you don't want is people referencing a health worker and saying that health worker said, I'm not going to take the vaccine, because I don't know what it will do to me in 10 years. I think we need to really ensure that our health workers understand the benefits of vaccination, but also that they understand that myths and conspiracy theories come with every large outbreak. So this is a pattern of human behavior where you have the outbreak and then people ascribe it to some other source apart from the scientific reason. So I think as we learn, that this is actually not an unusual thing for communities to have divergent beliefs about a new vaccine, then we can communicate more effectively.
And I just wanted to add that there is a ministry advisory committee in South Africa on behavioral change and on the traditional behavior. And they are looking at this and they are supporting the vaccine program very, very strongly. So I totally endorse what Mohammed and Elizabeth have said. We as IPC practitioners or those with an interest in infection control and indeed the health of our people must make sure that we can convince more and more people to take the vaccine should it be made available to them. I would love to hear from the CDC as well, but unfortunately, one day's this thing has gone off. But I'd love to hear from them as well, because there is a plan. I know I've seen a draft of the plan that they have for their vaccine program for Africa.
Thank you very much. I need to stop us here. We're over our time already for 7 minutes. I just want to also ask everybody and ask you to participate next week as well, when we will do week 4 of this series. We're looking forward to have all of you again on this call. Also, I want to just mention that the French version will be on Friday, as we normally do. So there was today no French translation. That will happen on a Friday. So every week on a Wednesday, we will have the English one with the translation into Arabic and Portuguese. And on Friday, we will have a French version of this discussions. Thank you very much, everybody, and have a great day. Goodbye.
Thank you, everybody. Thanks a lot, CDC, and thanks a lot, Anna. Bye.
Bye.
Bye, all.
Thanks, everyone.
I don't care. I just came here to have a Japanese passport. I don't care about education.
Japanese passport? How's it going to be? Oh, I don't know. Yeah.
Cheers and cheers.
All right. You guys did a good job today, so it really deserves some sort of